Hello, my dear lovely friends. A very good evening to all of you. I hope you would have revised that particular story which we discussed without any workbook or anything in oncosurgery. And I hope that many of the things in oncosurgery are already in your control. So if we just try to take a look what we were discussing, we were talking about the GI malignancies. In GI malignancies, basically, just by looking at this, I think we should be able to sort the things like oral malignancies we talked about, the squamous cell carcinoma. In India, it is at the bucco-alveolar complex, or you can say the gingivobuccal sulcus, because of people who are eating the tobacco and keeping the tobacco quid in their mouth. While in Western countries, it is because of smoking, so it is on the lateral border of tongue, middle one-third. Esophageal cancer, we discussed about the squamous cell carcinoma story and the adenocarcinoma story in the lower esophagus. We saw the different risk factors for esophageal cancer. We saw how this cancer grows as a polyp, how it can cause dysphagia, regurgitation, aspiration and lung complications. We saw that how we need to actually approach these patients of dysphagia, barium swallow. If we find something on barium swallow, then we do upper GI endoscopy, take a biopsy. For staging, we do a CECT. For depth, we can do endoscopic ultrasound, and for metastasis, we do a PET scan. Based on this, we can do a TNM staging for esophageal cancer. T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs, T4A pleurapericardium, diaphragm, T4B trachea, bone, aorta. N1 1 to 2 lymph nodes, N2 3 to 6 lymph nodes, and N3 7 or more than 7 lymph nodes, M1 distant metastasis. Based on this, we can decide what is the stage of cancer. The best curative treatment what we have for esophageal cancer is surgery. In surgery, we have to take a proximal 10 and distal 5 centimeter. Why we take a longer proximal margin? Because if there is a cancer in this area, then the lymphatic spread is taking place in the upward direction. And here, if we go into further details of oncosurgery, where the standard textbook of oncosurgery actually is DeVita, they have mentioned that esophagus, lymph nodes around the esophagus, they have got a satellite spread also. That means many a times if suppose there is a cancer in this area, this lymph node will be involved. And since there are satellite communications with the other lymph nodes, especially in the upward direction, so those lymph nodes can also get involved. That is why we take a proximal higher margin, 10 centimeters. That is why we have to do a total esophagectomy through a transthoracic approach. Many times we can give 5-FU and cisplatin before surgery to reduce the tumor. That is a neoadjuvant chemotherapy what we can use. Complications of this surgery when we are doing stomach as a tube for reconstructing the esophagus, early complication can be anastomotic leak and late esophageal strictures can occur. Then we talk the story inside the stomach. In the stomach, we know it is an adenocarcinoma story. In developing countries as well as in India, it is the distal part of the stomach where the H. pylori is living, the prepyloric region. In Western countries, it is the gastroesophageal reflux causing cardia of the stomach. So malignancy in Western countries are seen near the gastroesophageal junction, in the esophagus, the lower esophagus, in the stomach, the upper stomach, that is the cardia of stomach. We have seen the various risk factors why stomach cancer can occur. We saw how this cancer can grow. It can grow as an ulcer, it can grow as a growth, sometimes diffuse growth in the stomach, that is a leather bottle stomach or Linitis plastica. Early advanced, if muscle is involved, that is advanced. There is a molecular classification related to Epstein-Barr virus. Then we talked about how these patients can present. There can be a mass in the epigastrium. There can be melena or hematomasis. Mass, first we do ultrasound. If we find a tumor, we do upper GI endoscopy and biopsy. Melena, stool for occult blood. If that is positive, do upper GI endoscopy. And if you see a tumor on endoscopy, you can take a biopsy. Investigation of choice, upper GI endoscopy biopsy, staging, CECT, depth of tumor endoscopic ultrasound, distant metastasis PET scan. TNM staging, T1 submucosa, T2 muscle, T3 subserosa, T4A penetrate through the serosa and T4B adjacent organs, N1 1 to 2, N2 3 to 6, and N3 more than 7 or 7. N3 7 to 15, N3B more than 15 lymph nodes. M1 distant metastasis. Based on the staging, we can do the different treatments. The treatment of choice is surgery, where we take 5 centimeter margin. If there is a cancer in the proximal stomach, we land up in doing a total gastrectomy, and here lies the short gastric vessels all around. So many a times the lymph nodes which are present on the short gastric vessels, they are actually going right up to the hilum of the spleen. In order to remove those lymph nodes right at the hilum of the spleen, we land up in doing a splenectomy. So proximal gastric cancer, total gastrectomy with splenectomy. Distal gastric cancer, if the story is confined within the stomach only, then we are doing a partial or subtotal gastrectomy. If the story extends into the pancreas, then we also have to remove the head of the pancreas in these situations. Right. The cancers in the duodenum, jejunum and ileum are rare because continuous peristalsis will not allow the carcinogens to stay in this area. So we don't find patients too often, we don't find MCQs. Your examiners are also not focusing on malignancy in this duodenum, jejunum and ileum area. Now we come to the large intestine, the cecum, the ascending, the transverse, the descending colon, the sigmoid colon, the rectum and the anal canal. We know that rectum and sigmoid, they are the reservoirs, so maximum chances of staying of carcinogens would be in the rectum and sigmoid. So this is the commonest site of malignancy in the colorectal cancers. 38% occur in the rectum and 21% in the sigmoid colon. Obviously, this is an adenocarcinoma. Let's take a look at the story of these colorectal cancers. So herein, if we take a look, like in this particular picture, which is showing the distribution of malignancy, 38% in the rectum, 21% in the sigmoid. Most commonly, it is a adenocarcinoma. Most common site is the rectosigmoid. Risk factors, what we know about. Generally, GI cancers are related to what you eat. आप क्या खाते हैं? That is one of the most important factor for GI malignancies. People who take more amount of red meat, animal fat, less amount of fiber, vitamins and antioxidants, smoking spirits. Polyps are quite common in the colon, especially the adenoma term anywhere in GIT is a dangerous term. So adenomatous polyps have got high chances of malignancy. There is a condition called as familial adenomatous polyposis, which may be associated with Gardner and Turcot syndrome. Apart from this, there is a Link syndrome, which is hereditary non-polyposis colon cancer. Inflammatory bowel diseases like Crohn's and ulcerative colitis can be associated with malignancy in the colorectal area. Radiation, APC gene mutation, these are some important factors. And even cholecystectomy. Because after removal of the gallbladder, there is no storage for bile salt, bile acid. So bile acids are increased in the colorectal area, and that carries the risk of cancer. Now, bit of familial adenomatous polyposis. It is an autosomal dominant condition associated with mutation in the APC gene. In 50% of patients of FAP, there is congenital hypertrophy of retinal pigment epithelium. More than 100 adenomatous polyps is diagnostic of familial adenomatous polyposis. This image, what you are seeing, beta, the same image has been asked in your exams. If you carefully take a look, these are the polyps. All these what you are seeing, these are the polyps. These These are adenomatous polyps. For writing purpose, we are writing that more than 100 adenomatous polyps, but actual scenario is that these polyps are countless. गिने भी नहीं जाते, हजारों में होते हैं ये polyps. These are in thousands. FAP associated with Gardner's syndrome and Turcot syndrome. Gardner's syndrome is when FAP is associated with epidermoid cyst. And sometimes we also find desmoid tumors. Turcot syndrome is when FAP is associated with brain tumors. And obviously, beta, these are adenomatous polyps, so there will be very high risk of cancer in this condition. Just a passing reference about a image-based question in dermatology. This is a hot image-based question what is coming up, usually related to dermatology. Herein you can see the pigmentation of the lips. This is a melanin pigmentation. Melanin pigmentation of the lips, or maybe the buccal mucosa. Sometimes on the hands and forearms. Here you can see the buccal mucosa. This condition sometimes is associated with juvenile polyps in the colorectal area. That is called as Peutz-Jeghers syndrome, familial hematomatous polyposis. In this condition, there are multiple juvenile polyps. In the intestine, associated with melanin pigmentation. Of lips, buccal mucosa, hands and forearms. Hands and forearms. Now, how the cancer grows in the colorectal area? Herein, the right-sided colon cancers, they are ulcerative, and left-sided colon cancers are annular or proliferative. Right-sided commonly present with bleeding, left-sided commonly presents with traffic jam, obstruction. Right colon cancer presents with bleeding, left colon cancer presents with obstruction. Rectal cancer, most common presentation is bleeding per rectum. Apart from this, an important thing what we need to understand, beta, if we just try to take a look at the midgut and hindgut, you know, right from third part of duodenum, fourth part of duodenum, jejunum, ileum, cecum, ascending colon, and proximal 2/3 of transverse colon. This is the territory which belongs to superior mesenteric artery. And behind this, the distal 1/3 of transverse colon, this descending colon, the sigmoid colon, this territory belongs to inferior mesenteric artery. So if there is a malignancy in this territory, then this will be drained by superior mesenteric vein. So if the cancer cell spread from the superior mesenteric vein, here in this image you can see this is the superior mesenteric vein, this is the inferior mesenteric vein, this is the splenic vein, and this is the portal vein. So if the cancer cells are going into the superior mesenteric vein, they would be going into the liver. That is why liver is the commonest site of metastasis in colorectal malignancies. If we talk about malignancy in this left side of colon, then this is going to go into the inferior mesenteric, inferior mesenteric vein opens into the splenic, this opens into the portal, and that is how liver metastasis. 1/3, 33% of colorectal cancer patients present with liver metastasis. For a patient who is presenting with bleeding per rectum, we need to do colonoscopy. Investigation of choice for colorectal cancer would be colonoscopy. And please remember, beta, the entire colon has to be screened. It is not just that we pass the endoscope into the anus, rectum, and sigmoid colon, and if we find a cancer in the sigmoid colon, we feel that, okay, now the scopy is sufficient. We may find a cancer in the sigmoid. We may also find some synchronous metachronous lesions in the other parts of the colon. So a full colonoscopy has to be done. And when you are doing a colonoscopy, beta, there is a possibility that you may find something like this. You will not find me inside the colon, right? So here you can see there's a tumor, and now you can take a biopsy from this tumor. Colonoscopy and biopsy. Please remember, we always go for full colonoscopy. If by chance we are doing barium enema, then we can find a apple core appearance on barium enema. Cancer in any tubular structure. If it is circumferential, only the lumen will be seen by the contrast. So beta, once the diagnosis is made, staging, we know this is the abdomen. So in the abdomen, we are doing CECT. But if it is rectum or anal canal, that would be the pelvic area. So there we will be doing MRI. For depth of tumor, we know we can do endoscopic ultrasound. And for distant metastasis, the same story, beta, PET scan. This is how oncosurgery becomes so easy. Once we have understood the concept, then there is no confusion in choosing the different investigations. In TNM staging, N stands for number of lymph nodes. That is what we have been talking about in GIT. Now herein, the same story, beta. T1 submucosa, T2 muscle, T3 subserosa, and T3 through the serosa into the adjacent organs. If you remember stomach, T1 submucosa, T2 muscle, T3 subserosa, T4A penetrate the serosa, and T4B adjacent organs. Lymph node staging, here there is a slight change. Esophagus and stomach 1 to 2 lymph nodes, colorectal 1 to 3 lymph nodes. N2 in esophagus and stomach 3 to 6 lymph nodes. Here N2 is just 4 or more than 4 lymph nodes. So N1 in colorectal cancer 1 to 3, N2 4 or more than 4 lymph nodes. M1 is distant metastasis. Again, if we have to choose between the different options to fight against cancer, surgery, chemo, radio, hormonal, and targeted therapies, the best treatment option is surgery. And herein, for colon cancer, the margin of resection to be taken is 5 centimeters, while for rectal cancer, it is 2 centimeters, wherein nowadays, in rectal cancer, the distal margin can even be 1 centimeter, right? So for colon cancer, we have to take a 5 centimeter margin. Now, just imagine, beta, this is an image which is showing that there is the cancer in the right half of the colon. When you have to take a 5 centimeter margin all around, we actually land up in removing the right half of the colon. So this is what we call as right hemicolectomy. Same way, if there is a cancer here, beta, as you can see here, you land up in removing left half of the colon, that is left hemicolectomy. So we have got the options of right and left hemicolectomy. Sometimes, if suppose we say that cancer is situated somewhere here, then we might have to remove this part of the colon. That means we might have to extend this margin here, and this is what we call as extended right hemicolectomy. So tumors which are situated at the hepatic flexure of colon, we are doing extended right hemicolectomy. The challenge which we might face would be in rectal cancers. Now suppose we are talking about a cancer in the rectum. If there is a cancer here in the rectum, let us try to understand. Suppose I say, beta, this is the rectum, and here I say is the anal canal. We know that God has given a sphincter in the anal canal, so here lies the sphincter. It is only because of this anal sphincter, beta, we are able to control the fecal discharge. If by chance the surgeon damages this anal sphincter, patient will not be able to control the fecal discharge. Patient will land up in fecal incontinence. So if we just remember this point, suppose there is a cancer in the upper part of rectum here, we have to just take a 2 centimeter margin. So maybe we are chopping the rectum somewhat like this. This is called as anterior resection of the rectum. If suppose I say that cancer is situated in the middle of the rectum, suppose here, now here also you will be taking a 2 centimeter margin, so you might have to go a little down and you might remove this like this. This is called as low anterior resection. But the challenge what we will face is if the cancer is situated in the lower third of the rectum. Now if there is a cancer in the lower third of the rectum, suppose here, this becomes a challenge for us. Here lies the anal sphincter, and we cannot damage somebody's anal sphincter. So 2 centimeter proximal, and maybe if we are able to get even 1 centimeter distal margin, then also that is considered acceptable nowadays, and we can go ahead with the low anterior resection. Many a times, if we feel a little insecure, nowadays with the advancement in technologies, we have got an option that we can pass a endoscope, we can pass a circular stapler from below, endoscopic circular stapler from below, and we still try to resect this rectum without causing damage to the anal sphincter. If it is possible to do a endoscopic circular stapler, low anterior resection of the rectum, wonderful. But if by chance I say that the cancer is somewhat like this, or maybe suppose I say the cancer is somewhat like this, or maybe I say that cancer is somewhat like this, then in these cases we will have to damage the anal sphincter. And if we have to damage the anal sphincter, then we cannot keep this anal canal in the patient. So in these cases, what we do is we remove this entire story. We remove this entire story, rectum and anal canal, permanently forever. To do this, we need 2 teams of surgeons. One team would be working from the abdomen, another team here suppose is the anal opening. One team is working from the abdomen, that team is trying to dissect the rectum from above. Another team is working from the perineum and is trying to dissect the anal canal like this. When these 2 teams are able to meet with each other, then we believe that complete dissection has been done. This approach where abdominal and perineal, both the approaches are going to be used, this is called as abdomino-perineal resection. And once you remove somebody's rectum and anal canal for the whole life, you just have got the sigmoid colon above. You take the sigmoid colon out on the abdominal wall as a permanent sigmoid colostomy, and then patient can just put plastic bags over that sigmoid colon, and whatever fecal matter comes into that plastic bag, he has to just empty the plastic bags according to the movements of the fecal matter. Right. So in rectal cancer surgery, beta, we have got the options of doing an anterior resection, low anterior resection. We can do an endoscopic circular stapler sphincter preserving surgery. If anal sphincter cannot be preserved, then we have to do APR. This is abdominoperineal resection with permanent and sigmoid colostomy. With permanent and sigmoid colostomy for the whole life. In the GI tract, last is the cancer of anal canal. Anal canal cancers, we know, is something which is related to human papilloma virus infection. This is an image of the anal canal cancer. This is a squamous cell carcinoma. Human papilloma virus infection. Please remember, beta, cancers near the natural openings of the body, whether it is oral cancer, esophageal cancer, anal cancer, vaginal cancer, cervical cancer, even distal urethral cancer, they are commonly associated with human papilloma virus. This will be a squamous cell carcinoma. And we all can understand one thing here, that if there is a cancer in the anal canal, if we just take a look here and I try to create a cancer here in this area, if we have to do surgery, then we'll be damaging the anal sphincter of this patient. So surgery would be abdominoperineal resection with permanent and sigmoid colostomy. But nowadays, we have realized that if we avoid surgery and if we give a combination of chemotherapy and radiotherapy to anal canal cancers, then many a times this combination of chemo and radio is able to remove the anal cancer. So nowadays, surgery is not the treatment of choice for anal canal cancers. It is a combination of chemotherapy and radiotherapy which is commonly used for treatment. So treatment of choice for anal canal cancer is combination of chemo and radiotherapy. Chemotherapy and radiotherapy. This is called as Negro regime. इसको बोलते बेटा Negro regime. क्या बोलते? What do we call this? Negro regime. We can use chemotherapy in colorectal cancers. The chemotherapies which have been used in colorectal cancers are oxaliplatin. Targeted therapy in rectal cancer, what we use is cetuximab. We can use cetuximab as targeted therapy in rectal cancer. Right, so these were few relevant points about the anal canal cancer. Now let's take a look about the gallbladder malignancy. If we focus here, this is the gallbladder. This would be the cystic duct. So right and left hepatic duct, common hepatic duct, cystic duct, CBD, right? Majority of gallbladder cancers occur in the fundus of the gallbladder. Most common site is the fundus of gallbladder. And the reason for cancers developing in the gallbladder. They are gallstones. Even if we destroy the stones by some therapies like shock waves or something, the destruction of the gallbladder mucosa is such that this can lead to cancers in the gallbladder. So we don't want to take any chances. And even if we remove the gallbladder, it is not going to cause major challenges in the patient, because gallbladder is something which is not synthesizing bile. Bile is synthesized by liver. Even after you remove the gallbladder, the patient's bile will remain intact. The only thing is, bile we know is responsible for digestion of fats, emulsification of fats. If the patient takes a bulky fatty meal, then since there is no storage of bile, that bulky fatty meal will face problems in emulsification and digestion. Otherwise, if the patient takes normal amount of fats in diet, everything would be fine. Porcelain gallbladder is a condition in the gallbladder beta where there is deposition of calcium inside the gallbladder, high risk of cancer. Adenomatous polyps, especially if they are more than 10 millimeter in size. Typhoid carriers, salmonella, favorite place is gallbladder. So salmonella can cause damage inside the gallbladder. How these patients can present? Sometimes patient can present with cholecystitis, sometimes with a mass in the right hypochondrium, sometimes with jaundice. Why jaundice occurs? Usually gallbladder malignancies present with jaundice. The reason is very simple, beta. If there is a cancer in this area, gradually when the cancer crosses the gallbladder and goes inside the liver, then you can see it is going to damage the liver, and there inside the liver there will be mixing of bile with blood. So bile in blood is jaundice. That is why gallbladder cancers can present with jaundice. This is an image-based question which has already been asked in our exams. Herein you are seeing some mass type of lesion inside the gallbladder. So this is actually an image of gallbladder cancer. Investigation of choice. We cannot pass any endoscope inside the gallbladder, though we can pass endoscope into the common bile duct, but not inside the gallbladder. So we cannot take a percutaneous biopsy. Better to get a CECT of the abdomen done. For malignancy of the gallbladder, we have to do a radical cholecystectomy. That means we not only have to remove the gallbladder but also the lymph nodes around it. And also, my dear friends, if by chance the gallbladder cancer is going into the liver, then just by removing the gallbladder, the cancer is not going to go. So in these type of situations, we have to remove the gallbladder along with some part of the liver also, right? But if the cancer is confined within the gallbladder, then we just remove the gallbladder along with the lymph nodes. That is what we call as radical cholecystectomy. Removal of gallbladder with the lymph nodes. Last of the malignancies to be discussed in GIT is the pancreatic malignancy. Now here, before we start our discussion, let us try to understand the story. Suppose this is the esophagus, this is the stomach, here lies the pancreas, in this we know there is a common bile duct coming. We know there is a pancreatic duct. Majority of pancreatic cancers, they are seen in the head of the pancreas. Majority of cancers in pancreas are seen in the head of the pancreas. Another type of cancer is periampullary cancer. Now beta, this area what you are seeing, this is the medial wall of second part of duodenum. This CBD and pancreatic duct are opening at the ampulla of Vater, which is guarded by a sphincter of Oddi. There may be malignancies arising near the ampulla. For example, there may be a malignancy which is arising from the terminal part of common bile duct, or maybe the terminal part of pancreatic duct, or maybe the ampullary mucosa, or maybe the duodenal mucosa close to the ampulla. These malignancies arising from the terminal CBD, terminal pancreatic duct, ampullary mucosa and duodenal mucosa close to the ampulla, this is called as periampullary carcinoma. Out of these two malignancies, head of pancreas malignancy is much more common. Most common malignancy of the pancreas is carcinoma of head of pancreas. Most commonly, both are adenocarcinoma. Even gallbladder, beta, this is also a adenocarcinoma. Even gallbladder is a adenocarcinoma. Pancreas is also adenocarcinoma. Second most common malignancy here is a periampullary carcinoma. The risk factors include smoking, chronic pancreatitis, diabetes, and hereditary stories. Now, these malignancies most commonly present with jaundice. And this is what we need to understand, beta. Just have a look. We know that this tumor which is confined in this area is not going to cause jaundice. But just imagine that when this tumor is growing, and it is putting pressure on the common bile duct, then there will be a traffic jam to the bile flow. Then the patient will present with jaundice. And it is believed, beta, that if we talk about carcinoma of head of the pancreas, as the tumor is growing at this stage, patient is not having any problem. But as the cancer keeps on growing and starts putting pressure on the common bile duct, then the patient develops jaundice. Most common presentation of these malignancies is jaundice. But jaundice is a late presentation in carcinoma head of the pancreas. Also, beta, once the patient has developed jaundice in carcinoma head of the pancreas, then this jaundice will keep on increasing unless and until you remove the cancer. While if we talk about periampullary cancers, periampullary cancer which is growing in this particular area, even if it's a small tumor, you can imagine, beta, that since the bile has to flow through this area, even a chota sa tumor, a small tumor here, may cause traffic jam in the bile coming into the duodenum. So these patients present with jaundice very early. That is the reason why periampullary carcinomas present early, they can be diagnosed early, they can be treated early, and that is why they have got a better prognosis as compared to carcinoma head of the pancreas. Also, beta, what we have seen sometimes, if there is a cancer developing here, traffic jam to the bile flow, proximal pupil dilated, pressure in the proximal system increases, the proximal muscles may contract forcefully and may try to throw the bile with pressure. And many times when bile is coming with pressure, the tumor cells which were trying to block the bile duct, they are shed off into the duodenum. That means if the tumor cells are shed off into the duodenum, the traffic jam can be cleared and the bile starts flowing into the duodenum. I repeat, in periampullary cancers, if this tumor starts causing obstruction in the bile duct, definitely the patient is going to present with jaundice. Sometimes what we see, because of this, the proximal pupil dilate, pressure in the proximal system increases, the proximal muscles contract forcefully in order to throw the obstruction out, and many times we see that the tumor cells, they shed off into the duodenum because of the bile pressure. As soon as the tumor cells are shed off, the traffic jam can be cleared and the jaundice will disappear. Again, the tumor is going to grow. Again, the same story is going to happen. That means in periampullary carcinoma, jaundice is the commonest presentation. Jaundice occurs early, but it is a waxing, waning type of jaundice. Jaundice बढ़ता है, कम होता है, बढ़ता है, कम होता है. waxing waning type of jaundice in periampullary carcinomas. In carcinoma of head of pancreas, jaundice is the commonest presentation, but jaundice is late, and once jaundice occurs, it is a progressive type of jaundice. It is not going to increase or decrease unless you remove the tumor. While in periampullary cancers, jaundice appears early and it is a waxing and waning type of jaundice. Apart from this, pancreatic cancers, there is marked weight loss, and there is a Courvoisier's law which can be used sometimes in pancreatic cancers. It is said, beta, the common sense what we know, that if by chance there is any traffic jam in the bile duct, the proximal people are going to get dilated. That means whenever there will be any traffic jam in the bile duct, the gallbladder should always be distended. This is true. If there is a cancer in the pancreas which is putting pressure on the bile duct, the gallbladder is always distended, always palpable. But it is also true that if suppose we say that there are stones inside the gallbladder, and suppose the stone has come here and the stone is causing a traffic jam situation, then ideally majority of the times the proximal people dilate, the gallbladder is distended and palpable. But sometimes there is a possibility, beta, that if these stones were present in the gallbladder for a long period of time, and if they would have caused inflammations in the gallbladder multiple times earlier, then chronic infection would have occurred, healing would have occurred by fibrosis, and fibrous tissue contracts, and in those cases the gallbladder may be narrow and contracted. So Courvoisier said that if CBD obstruction is due to cancer, gallbladder is always palpable. But if CBD obstruction is due to a stone, gallbladder may not always be palpable. That is because the stones, if present for a long period of time, would have caused chronic fibrosis in the gallbladder, because of which the gallbladder might have become narrow and contracted, and now that narrow contracted fibrotic gallbladder will not be able to distend. So according to Courvoisier's law, gallbladder is always palpable. If CBD obstruction is due to cancer, but gallbladder is not always palpable if CBD obstruction is due to stone, and the reason is chronic cholecystitis. In chronic cholecystitis, we find a narrow contracted gallbladder. Narrow contracted gallbladder. Another question which I want to ask you, beta, if you take a look, in which out of these two malignancies you would be able to take an endoscopic biopsy? Will you be able to take a biopsy from periampullary cancer, or will you be able to take a biopsy from head of pancreas cancer? We know, beta, upper GI endoscope, that upper GI endoscope is passed through the mouth, through the esophagus, stomach, and this is coming into the duodenum here. Through the side channel of this endoscope, we can pass the instruments. We can take a biopsy forceps through this, and now we can see that for periampullary cancer, yes, we can take a biopsy, but we'll not be able to take a biopsy from head pancreatic cancer. So investigation of choice for periampullary carcinoma is ERCP and biopsy, but investigation of choice for pancreatic head cancer, it is CECT of the abdomen. CECT of the abdomen. For carcinoma head of the pancreas, CECT of the abdomen, while for periampullary cancer, we can do ERCP and biopsy. Tumor marker for pancreatic cancer is CA19-9. This is a pathology question. No controversies, beta. If you have got CA19-9 in the option, that is the best answer for tumor marker for pancreatic cancer. If CA19-9 is not given in the option, then you can go for CEA. CEA is carcinoembryonic antigen. Carcinoembryonic antigen. In the treatment for pancreatic cancers, no chemotherapy, no radiotherapy, no hormonal therapy, no targeted therapy. Only surgery is what helps. And the principle of surgery, we know that we have to remove the tumor along with adequate margin. Now, beta, if you have to remove the tumor along with adequate margin, just have a look here. If there is a cancer here, then you will have to remove this part of the pancreas. That means you have to remove the head of the pancreas. And we all know, beta, that pancreas is fused with the duodenum. Duodenum को pancreas से कोई जुदा नहीं कर सकता. So whenever we have to do surgery for this cancer or maybe this cancer, we actually have to remove the head of the pancreas along with the duodenum. And that is what we call as pancreaticoduodenectomy. In this operation, beta, just imagine that if you are doing a pancreaticoduodenectomy, suppose this is the CBD which is going up, and here you know would be the cystic duct, the gallbladder and the common hepatic duct, the right and the left hepatic duct. Something like this. Now in this, what we do is we have to remove the head of the pancreas, we have to remove the duodenum, we offer a scheme to the patient that we remove the gallbladder free of cost. Something like this. If you are chopping all this area off, then what you will be left with is something like this. You will be left with the stomach here. Something like this. About definitely would be the esophagus. Now herein you are left with this part of the pancreas. And here in this pancreas, definitely there would be a pancreatic duct. Here you will be left with the right hepatic duct, the left hepatic duct and the common hepatic duct. So this is what you are left with. You know, beta, that food is coming into the stomach. Rasgulla, idli, dosa is coming in the stomach. Pancreatic juice is coming in the pancreatic duct. And bile is coming in the common hepatic duct. You want that food should be mixed with bile and pancreatic juice. So we take the help of the innocent guy, जो शरीफ आदमी हमारे पास है, उसी की मदद लेते हैं और उसी को बोलते हैं कि भैया अब आप ही इन तीनों से जुड़ जाओ. We just request the jejunum and we connect the jejunum with the hepatic duct, stomach and the pancreatic duct. First we do a pancreaticojejunostomy, then the hepaticojejunostomy and then the gastrojejunostomy. This is Whipple's operation or a triple bypass operation. If we take a look at the actual image of this Whipple's operation, this is what you are seeing here. In this case, beta, suppose there is a tumor in the head of the pancreas or maybe periampullary. You have removed the head of the pancreas, you have removed the duodenum, you have removed the gallbladder and the common bile duct. You are left with the common hepatic duct, the stomach, and the pancreatic duct. So now what we are doing is, we have requested the jejunum and we connect the jejunum with the pancreatic duct. This is a pancreaticojejunostomy. Then we connect the common hepatic duct with the jejunum. This is a hepaticojejunostomy. And then we connect the jejunum with the stomach. This is the gastrojejunostomy. So food is coming here and pancreatic juice and bile is also coming here. This is a triple bypass or a Whipple's operation. Nowadays, we are doing a little modification of this classical Whipple's. We are trying to preserve the pylorus also, and we are connecting the pylorus instead of the prepyloric region with the jejunum. That is called as pylorus preserving pancreaticoduodenectomy. Pylorus preserving pancreaticoduodenectomy. This is the Whipple's operation or a triple bypass operation where we are doing a PJ, HJ and GJ. Pancreaticojejunostomy, hepaticojejunostomy and a gastrojejunostomy. Moving from GIT cancers, if we quickly rewind these colorectal malignancies, anal canal, gallbladder and pancreatic malignancies. Colorectal malignancy, most common it is the adenocarcinoma, most commonly the rectosigmoid area. Why these cancers occur? Red meat, animal fat, less fiber, less vitamin antioxidant, various polyps, adenomatous polyps, familial adenomatous polyposis like Gardner-Turcot syndrome. Another syndrome associated with colon cancer is Link syndrome, which is hereditary non-polyposis colon cancer. Other causes may be genetic APC gene mutation, radiation, inflammatory bowel diseases like Crohn's and ulcerative, where ulcerative colitis has got more risk, cholecystectomy. All these can cause colorectal cancers. How the cancer grows: right colon, ulcers, left colon, annular, tubular, obstructive. That is why right colon cancer is commonly present with bleeding, left colon cancer is present commonly with obstruction. However, rectal cancer, the commonest presentation is bleeding per rectum. Also, we discussed that 1/3, 33% of colorectal malignancies, by the time patient comes to us, the patient already has got metastasis in the liver. In our clinical approach, with a patient presenting with bleeding per rectum, elderly person, we do a colonoscopy and it should be a complete whole colonoscopy. If we are able to see the tumor, we can take a biopsy, staging CECT, depth endoscopic ultrasound, metastasis 18-fluorodeoxyglucose PET scan. With that, we can do the staging: T1 submucosa, T2 muscle, T3 subserosa, T4 adjacent organs, N1, 1 to 3 lymph nodes, N2, 4 or more than 4 lymph nodes, M1 distant metastasis. The best treatment option is surgery. 5 centimeters for colon cancer, 2 centimeters for rectal cancer, even distal 1 centimeter is acceptable for rectal cancers. For colon cancers, right-sided colon cancers, right hemicolectomy, left-sided left hemicolectomy. For cancers situated in the hepatic flexure of colon, we can do an extended right hemicolectomy. For rectal malignancies, upper rectum anterior resection, middle rectum low anterior resection, and lower rectal cancers, we are doing endoscopic circular stapler sphincter preserving surgery. But if we cannot preserve the sphincter, then we have to do abdominoperineal resection with permanent end sigmoid colostomy. The chemotherapy, what we are commonly using in rectal cancers, is oxaliplatin. And colorectal cancers, the targeted therapy which we have used is cetuximab. Anal canal cancers, most often related to human papilloma virus, squamous cell carcinomas, treatment of choice is combined chemotherapy and radiotherapy, that is Negro regime. If by chance this chemo radio fails, then we have to do surgery, that is APR. Gallbladder malignancy is most common seen in the fundus of gallbladder, related to stones inside the gallbladder, porcelain gallbladder, adenomatous polyps more than 10 millimeter in size, typhoid carriers. Patients can present with cholecystitis, mass or jaundice. Depending on how the patient presents to us, if patient comes to us with jaundice, first we do LFT, then ultrasound. If patient comes to us with a mass, first ultrasound and then LFT. Since we cannot pass any endoscope into the gallbladder, so investigation of choice would be CECT. We will not take percutaneous biopsy because of the risk of spillage of cancer cells. And the treatment for gallbladder malignancy would be radical cholecystectomy, removal of the gallbladder along with the lymph nodes. For pancreatic cancers, they are adenocarcinomas, most commonly situated in the head of the pancreas, second most commonly in the periampullary region, that is terminal CBD, terminal pancreatic duct, ampullary mucosa or duodenal mucosa close to the ampulla. Associated with smoking, chronic pancreatitis, diabetes and hereditary reasons. Whether it is head pancreas or periampullary, most commonly presents with jaundice. However, jaundice appear late in head of pancreas, and jaundice in head of pancreas cancer is progressive. While periampullary cancer, jaundice occurs early and it is a waxing and waning type of jaundice. Pancreatic cancers patients have got marked weight loss. There is a Courvoisier's law which says that gallbladder will always be palpable if CBD obstruction is due to cancer, but gallbladder may not always be palpable if CBD obstruction is due to stone, and that is probably because if gallbladder has suffered from chronic cholecystitis, the gallbladder would have become narrow and contracted. In our approach to these patients presenting with jaundice, first we do LFT, then ultrasound. If we come to know that there is some solid tumor in this area, if there is a tumor near the ampulla, we do ERCP and biopsy. If there is a tumor in the head of the pancreas, we do CECT of the abdomen. The tumor marker, what we commonly use for pancreatic malignancy, is CA19-9. The second is carcinoembryonic antigen. In the treatment for pancreatic cancers, the mainstay of treatment is surgery. No role of chemo radio in pancreatic cancers. In surgery, we have to remove the head of the pancreas along with the duodenum, that is pancreaticoduodenectomy. Now we are trying to preserve the pylorus also, so pylorus preserving pancreaticoduodenectomy. After chopping all this, definitely we also remove the gallbladder in this operation. So we are left with the pancreatic duct, the common hepatic duct and the stomach. We request the jejunum and connect the jejunum with all these three: pancreaticojejunostomy, hepaticojejunostomy and gastrojejunostomy. A triple bypass operation. So this is all about the colorectal cancers, the anal canal cancers, the gallbladder and the pancreatic cancers. Right. Now we move into the urinary tract. In the urinary tract, Peter, as we can see, the kidney, the urinary bladder. Bladder is a reservoir. So the commonest site of malignancy in the entire urinary tract would be the urinary bladder. This is the outer part of the kidney. We know there are millions of nephrons here. And they have got their collecting ducts. The collecting ducts, they open in the minor calyces. Which forms the major calyces. And these major calyces form the renal pelvis. And then comes the ureter. That means this area what we are seeing. This is the pelvic-calyceal system. And here lies the ureter. And the ureter is opening into the urinary bladder. And then there is urethra. The entire urinary tract, right from the pelvic-calyceal system, ureter, bladder and urethra, the role of this is just passage of urine. So this whole story is lined by transitional epithelium. That is why you find transitional cell carcinomas in this whole story, except the distal urethra, where as the external urethral opening is coming, so this has to be lined by squamous. So in distal urethra, you can find the squamous cell carcinomas. However, this outer portion of the kidney, this is having the columnar lining. So this area would be having the adenocarcinoma. That means in the kidney, we can have adenocarcinoma here and transitional cell carcinoma here. Out of these two, adenocarcinoma is more common. That is why commonest malignancy what we see in the kidney is a adenocarcinoma. This whole story would be transitional and this story will be squamous, right? As there are millions of nephrons here, when the tumor starts growing in the nephron, like in the proximal convoluted tubule, it is not only the tumor cells which are growing, but also the blood vessels are growing. And when the blood vessels break, they can bleed. And if they bleed, then maybe there might be bleeding. And this bleeding would be coming here. And that is how these patients can present with blood in urine, hematuria, painless hematuria, right? The commonest presentation of kidney and bladder cancer is a painless hematuria, right, beta? Before we actually discuss about this kidney cancer in adults, just a passing reference about a Wilms tumor in babies. This Wilms tumor in babies, also called as nephroblastoma, commonly seen in babies less than 5 years of age. This is a mixed tumor as it contains both epithelial and connective tissue elements. Both epithelial and connective tissue elements. And Wilms tumor has been associated with inactivation of Wilms tumor suppressor genes. Those genes which keep the Wilms tumor suppressed, if they become inactivated, then the baby have chances of developing this Wilms tumor. There are two genes, WT1 and WT2. Inactivation of WT1 has been associated with various syndromes like Weger syndrome and Dennis-Drash syndrome. Inactivation of WT2 is associated with Beckwith-Wiedemann syndrome. Most commonly, these Wilms tumor are seen at the upper pole of kidney. And most commonly, small babies, if there is a mass which is growing in the kidney, these babies present with mass in the abdomen. Mass in the abdomen. Sometimes there can be pyrexia and hematuria. This is the Wilms tumor baby beta. If there is a tumor developing in the kidney here, this tumor presents as a mass in the abdomen. Small babies, their abdominal muscles are lax. Whenever there is any organ enlargement inside the abdomen in small babies, usually they present as abdominal mass. You are able to palpate those masses. That is why Wilms tumor commonest presentation is abdominal mass. Tumor may produce certain substances which can lead to pyrogens and pyrexia. Investigation of choice for tumors which are growing in the outer part of kidney. Look at the screen, beta. Look at the screen here. Suppose I say that there is a tumor which is growing in this part, and if you are doing a endoscopy, beta, you would be passing the endoscope like this. So if there is a cancer in the urethra, then urethroscopy and biopsy. If there is a cancer inside the bladder, then cystoscopy and biopsy. If there is a cancer in the ureter, then ureteroscopy and biopsy. This endoscope, you can take this endoscope right up to this area. That means cancers in the urinary tract right up to the pelvic calyceal system. You can pass the endoscope and take a biopsy, but you will not be able to pass this endoscope into this outer part of the kidney. Whether it is a Wilms tumor or it is an adult kidney cancer, they are growing in this part, so we cannot take a biopsy. We know percutaneous biopsies can cause spillage of cancer cells, so the investigation of choice remains CECT of the abdomen. So here we are doing CECT of the abdomen. And in the treatment for Wilms tumor, beta, since it is a mixed tumor, it responds to all forms of therapies, surgery plus chemotherapy. We can even use radiotherapy in the treatment of Wilms tumor. Like for stage 1 and 2 Wilms, we use surgery and chemo, while for stage 3 and 4, we also add radiotherapy. The surgery what we are doing for Wilms tumor is a radical nephrectomy. We remove the kidney along with lymph nodes. Remove the kidney along with the lymph nodes. So that is what we are doing for Wilms tumor. How many kidneys are there in our body? Good. So if one kidney is developing this, then you can remove that particular kidney. If we talk about something related to adult kidney cancer called as hypernephroma. Now, beta, most commonly, the adult kidney cancer is a adenocarcinoma. Most commonly, it arises from PCT, that is proximal convoluted tubule epithelium. Most commonly, it is a clear cell type. Most commonly, it is a clear cell type. There are various pathological types: clear cell, chromophobic, chromophilic. Most commonly, it is the clear cell type. The most important risk factor for kidney and bladder cancer is smoking. Apart from this, we discussed the life of a painter, carpenter, shoe polish wala, the various dyes and chemicals, the benzene dyes, naphthylamine, benzidine, azo dyes. It is because of this reason the kidney and bladder cancers are also called as industrial cancers. Kidney and bladder cancer are also called as industrial cancers. Apart from this, long-term use of non-steroidal anti-inflammatory drugs, long-standing stone inside the kidney, and a syndrome, von Hippel-Lindau syndrome. With esophageal cancer, we talked about a Plummer-Vinson syndrome. With colorectal cancer, we talked about Gardner syndrome, Turcot syndrome, and Lynch syndrome. With kidney cancer, there is a von Hippel-Lindau syndrome which can be associated. And we have been talking out time and again that commonest presentation of kidney and bladder cancer is a painless hematuria. Sometimes there may be pain and a mass in the lumbar region. Another interesting thing, we can find varicocele in kidney cancer patients. Now varicocele, beta, this is abnormal dilatation of pampiniform plexus of veins around the testis. Varicocele is simply abnormal dilatation of pampiniform plexus of veins around the testis. This is the normal anatomy what we are seeing here. In this case, this is the inferior vena cava, which is situated slightly onto the right. This is the abdominal aorta. This is the right kidney. This is the left kidney. This brown thing what you are seeing, the pelvic ileal system and the ureter. This is the right renal vein. Because IVC is slightly onto the right renal vein is short, the left renal vein is long. The right testicular vein opens directly into the inferior vena cava, but the left testicular vein opens into the left renal vein. Now just imagine, beta, if suppose there is a cancer in the kidney, suppose I say there is a cancer here versus a cancer here. If this cancer has to spread through blood, suppose it is a right-sided kidney cancer, and these cancer cells travel through the blood, they would be going into the right renal vein, and then they would be going into the inferior vena cava. That means they are not going to cause any traffic jam to the right testicular vein. This is free, right, initially. But if we talk about a left kidney cancer, and if it spreads to the left renal vein, this can cause a traffic jam to the flow of blood from left testicular vein into the left renal vein. Cancer in the left kidney, if it goes into the left renal vein, there will be traffic jam to the flow of blood from left testicular vein. Blood will not be able to go up nicely, so the blood will be getting pulled down into the spermatic veins and the pampiniform plexus of veins, leading to varicocele. MCQ people are interested in knowing which sided kidney cancers have more chances of varicoceles. So it is the left-sided kidney cancers which have more chances of causing left-sided varicoceles. Left renal cell carcinoma. Left renal cell carcinoma has more chances of causing left-sided varicoceles. Sometimes these kidney cancers, they produce certain substances which can lead to paraneoplastic syndromes. Patient can present with hypercalcemia. Patient can present with hypercalcemia, erythrocytosis, and raised ESR. Since the commonest presentation is painless hematuria, imagine a 60-70-year-old gentleman presenting with painless hematuria. The first investigation is urine examination, urine cytological evaluation, to rule out or to look for cancer cells. Please remember, beta ji, for 17th of December as well as in the entire life as a doctor, that whenever you come across a situation where the patient is presenting with blood coming out from somewhere, you should not ignore it. Even breast cancer can present with blood coming out from the nipple, right? So malign stomach cancers, right? So we have to be careful and we have to first evaluate. If suppose I say that urine examination is positive for cancer cells, that means there is malignancy in the urinary tract. If we take a look, which do you think will be more common? Bladder cancer or kidney cancer? Bladder cancer. So the next investigation, what you do if urine cytology is positive, you pass a endoscope into the bladder. And if you do not find any tumor inside the bladder, then you start thinking that now it can be a case of kidney cancer. If you find a tumor inside the bladder, you will simply take a biopsy, that is cystoscopy and biopsy. That is what we'll be doing for bladder cancer. So herein, the next step would be cystoscopy. And if we are talking about kidney cancer, then cystoscopy is negative. Now you do a CECT of the abdomen, and that will give you the whole idea. In the treatment for kidney malignancies, again, surgery is the only curative treatment. However, immunotherapy with BCG has been tried. Now, what surgery is supposed to be done? Depending on the size of the tumor, if the tumor is less than 7 centimeters, we do a partial nephrectomy. If the tumor is more than 7 centimeters, we do a radical nephrectomy. अगर छोटा कैंसर है तो पार्शियल, बड़ा कैंसर है तो रेडिकल. For example, if suppose there was a cancer here, then what we could have done was, if the tumor would have been less than 7 centimeters, then we would have removed the tumor somewhat like this, and we would have been able to preserve this kidney. Right? So this is partial nephrectomy. But if the tumor is more than 7 centimeters, then we have to remove the entire kidney, and this is the radical nephrectomy specimen. Tumor more than 7 centimeters in size. This, what you are seeing here, this is a cancer in the kidney. And for this, you have removed the entire kidney along with the lymph nodes. This has also been asked as a image-based question in your exam. The radical nephrectomy specimen. Right. So this is something about the kidney cancer. Now if we take a look at some relevant points about bladder cancer. Bladder cancer, as we have been discussing, majority of these bladder cancers, they are transitional cell carcinomas. However, other types can rarely be seen inside the bladder. Most common is transitional cell carcinoma. (90 to 95% of bladder cancers are transitional cell carcinoma, and this question has been asked multiple times in the exams. Rarely, we can find a squamous cell carcinoma and an adenocarcinoma also in the bladder. Now, squamous cell carcinoma can be associated with a parasitic infestation inside the bladder, that is schistosomiasis. Schistosomiasis, which is also called as bilharziasis. Adenocarcinoma in the bladder, ideally it should not be found because there is no columnar lining. But we know one thing, that during intrauterine life, there is a connection of the umbilicus with the bladder, which we call as allantois, which becomes the future urachus. Generally, this entire connection of umbilicus with the bladder closes before birth. But sometimes, if this connection persists even after birth, then urine, watery discharge will come out from the baby's umbilicus. That is an umbilical urinary fistula. Sometimes, only the umbilical part of this tract is patent. Mucus comes out from the umbilicus, umbilical sinus. Sometimes only the bladder part is patent, vesical end is patent, and that is a congenital urinary bladder diverticulum. And my dear doctors, it is in those situations If suppose there is a congenital bladder diverticula, then you can find this columnar lining related to urinary bladder, and then you can find this adenocarcinoma. Though it is very rare to find adenocarcinomas in the bladder, but if it is present, it is found at the dome or fundus of urinary bladder, in midline usually, antero-superiorly. In the bracket you can just write congenital urinary bladder diverticular story. For bladder cancers, beta, majority of bladder cancers are transitional cell carcinomas. And the commonest site for these tumors is either the lateral wall of bladder, or they may be found in the trigone, either the lateral wall of bladder or in the trigone area. So most common site for bladder cancer is the lateral wall of bladder and the trigone. Reason for bladder cancer, the same story beta which we have discussed in kidney cancer, the smoking dyes and chemicals. Pathologically, we can classify the bladder cancers into three types. If we take a look at the different layers of urinary bladder here, the innermost layer of urinary bladder, this is the mucosa. Just beneath the mucosa, there will be submucosa. And outside the submucosa will be the muscle layer. That is the muscle of the bladder beta, that is called as detrusor muscle. And then there will be adventitia. So these are the different layers of urinary bladder. Depending on what is getting involved, if suppose the majority of tumors, 70% of these bladder cancers, they are growing as a stalk from this mucosa, and they have got a frilly appearance. That means just like a papillary, finger-like projections are seen. So this is how the bladder tumors actually present. They are something like this, and they are arising from the mucosa. They can invade into the submucosa, right? If they do not invade into the muscle, these are called as non-muscle invasive. They are the most common bladder cancers. However, sometimes we can come across solid cancers, and solid cancers would be invading into the muscle. So if the cancer is going into the muscle, that is a muscle invasive. And the third variety is a flat, non-invasive. Now sometimes we can come across situations something like this. There may be flat, non-invasive, which are not even breaching the basement membrane, just like carcinoma in situ. So these are the three types. Most common type beta, that is the non-muscle invasive. The second one is a muscle invasive solid tumor, and very rare type is a flat, non-invasive carcinoma in situ type of cancers. So pathologically, there can be non-muscle invasive, muscle invasive, and flat non-invasive. Most common out of these three is non-muscle invasive. The flat cancers, because they are present at multiple locations, they are carrying a poor prognosis. And we know beta, whatever is the cancer, the commonest presentation is going to be painless hematuria. And if the patient presents with painless hematuria, you all know this, that first what we'll do is a urine cytology. urine cytology for cancer cells. If cancer cells are positive, then you start thinking of bladder cancer, and then you do a cystoscopy. You pass this endoscope, and when you do the endoscopy or cystoscopy, you can find something like this. Now this what you're seeing is a normal bladder mucosa, but here can you see something growing? All this what you're seeing, this is actually a tumor from the bladder. You are seeing other small tumor areas also. Can you see this area? Right? This area. So this is how most of the bladder cancers present to us. And when you're doing the cystoscopy, it is easy for you to take a biopsy from this tumor. So investigation of choice for bladder cancer would be cystoscopy and biopsy. You know, beta, bladder is almost lying in the pelvis. So staging investigation of choice for bladder cancer would be MRI. For pelvic cancers, bladder cancer, prostate cancer, penis cancer, rectum cancer, anal canal cancer, breast cancer, oral cancer, we are doing MRIs. While for thorax and abdomen, like esophagus, stomach, colon, gallbladder, pancreas, we are doing a CECT. Now, what should be done in the treatment for these bladder cancers? Very simple, beta. Just like TURP is done for benign prostatic hyperplasia, we can pass the cystoscope into the bladder, and then we pass a resectoscope into the bladder. If it is a non-muscle invasive cancer, we can just resect this tumor without removing the muscle. That is called as transurethral resection of bladder tumor, and that is the treatment of choice for majority of urinary bladder cancers, because majority are non-muscle invasive. So transurethral resection of bladder tumor is what we do. However, if there is a solid tumor in the bladder which is going into the muscle, then we have to remove the entire urinary bladder, radical cystectomy. For non-muscle invasive bladder cancers, we are doing TURBT, that is transurethral resection of bladder tumor. This is the treatment of choice for bladder cancers. However, for muscle invasive bladder cancers, we do a radical cystectomy. We remove the entire urinary bladder. Now you might be getting a lot of questions in your mind that how you can remove the urinary bladder. If there is a cancer, we cannot keep it. So if you remove it, then what? Then we try to create a new bladder. New bladder. Is it available at the chemist shop? No. So we try to create this new bladder from something inside the body. We can use the small intestine, ileum, to create a new bladder. Or if suppose we do not have that surgical expertise to create a new bladder, then we have to do something for the ureters, because we all understand that both the ureters are coming suppose from the kidney and they were actually opening into the bladder. But now what you are saying is you have removed the urinary bladder. So if you have removed the urinary bladder, then we take these two ureters and we can divert these two ureters in a isolated loop of small intestine, or maybe a isolated loop of large intestine. That means we can put these two ureters in the ileum or maybe the colon in a isolated loop. That is called as a ileal conduit or a colonic conduit. So when we do a radical cystectomy, after that, the option is either creation of a neobladder, and this neobladder can be created by using ileum, or we can do urinary diversion. Either ileal conduit or colonic conduit. Either ileal conduit or colonic conduit. That is how we can divert the ureters. So after moving away from the urinary tract area, we talked about the kidney malignancies, the bladder malignancies. Now let's take a look about the prostate cancer. In our earlier discussion, we were talking that prostate cancer is actually a part of the aging process. Prostate cancer is actually the commonest cancer in elderly males. Testicular cancer is the commonest cancer in young males. Prostate cancer is the most common cancer in elderly males. After 80 years of age, बेटा घर में अगर बुजुर्ग हैं तो please do take care of them. After 80 years of age, 70% of males suffer from prostate cancer, and this prostate cancer most commonly arises from the peripheral zone, causes enlargement of the posterior lobe, and it is a adenocarcinoma. Benign prostatic hyperplasia arises from the transition zone, causes enlargement of median and lateral lobes. Prostate cancer arises from the peripheral zone, causes enlargement of the posterior lobe. We do not know about any risk factor here. It is believed to be a part of the aging process. अगर मान लो कभी भगवान सपने में आए और बोले कि मुझे आपको दंड देना है, मुझे आपको कोई कैंसर देना है, मांगो कौन सा कैंसर मांगते हो, तो बिल्कुल बिंदास होकर बोल दीजिएगा कि प्रोस्टेट कैंसर दे दीजिए. It is a very slow growing cancer. Exact risk factor is not known, but the theory says it might be related to something androgens. Majority of these patients, they remain asymptomatic. It is a very slow growing cancer. Slow growing cancer. It takes years for the prostate cancer to grow, and it can spread. Locally, it spread upwards and laterally. Like in this particular picture, if I try to demonstrate better, suppose this is the prostate gland which is situated on either side of the urethra. If I say there is a cancer here, and now this cancer has to spread, so it usually spread in a upward lateral direction, and behind the bladder lie the seminal vesicles here. So involvement of seminal vesicles by this cancer can occur early, but involvement of urethra occurs late. That is what we have to remember, because if by chance this cancer would have been spreading medially, it would have caused traffic jam in the urethra, and then the patient would have presented with the symptoms early. But this cancer spreads upwards and laterally, so the seminal vesicles get involved early, but urethral involvement is late in prostate cancer. Through lymphatics, if we look at the prostate gland, the nearby lymphatics are the obturator lymph nodes, which drain into the iliac lymph nodes, internal iliac. We know beta that abdominal aorta divides into common iliac, Common iliac divides into internal iliac and external iliac. External iliac goes into the lower limb as femoral, popliteal, anterior posterior tibial and dorsalis pedis, while internal iliac goes towards the pelvis to supply the pelvic organs. So prostate is also receiving blood through that internal iliac. Lymph nodes are situated along the blood vessels. So usually those lymph nodes are getting involved which are actually lying on the blood vessels situated close to that particular organ. If the cancer spreads through blood, most commonly prostate cancer is going to bones. Breast cancer most commonly is going to bones. And bones which are commonly involved are the lumbar vertebra. Lumbar vertebra. There is actually a vertebral plexus of veins. This is a MCQ plexus beta. This is also called as Betson's plexus. Betson's plexus. There is a vertebral plexus of veins through which the cancer cells go into the lumbar vertebra, and because of this reason patient comes to us with low backache. Breast cancer also commonly spreads to lumbar vertebra through this vertebral Betson's plexus of veins. There is a slight difference in the nature of bony metastasis in prostate and breast cancer. Prostate cancer is something related to androgens. So probably prostate cancer bony metastasis may be associated with new bone formation. That means bony metastasis in prostate cancer are osteoplastic, while other malignancies bony metastasis are generally osteoclastic. अगर जैसे ब्रेस्ट कैंसर हड्डी में फैलता है तो ये हड्डी को तोड़ता है. Breast cancer, if it is spreading into the bones, it is going to break the bones. But prostate cancer spreading into the bones may be associated with new bone formation. That is why we say that bony metastasis in prostate cancer are osteoblastic. Breast cancer, they are osteoclastic. Bony metastases are common in these malignancies: P, B, K, B, T. P, prostate. B, breast. Kidney, bronchus, and thyroid. That means kidney cancer, lung cancer, and thyroid cancer also commonly spread to bones. But the commonest cancer spreading to bones in males, it is prostate. Commonest cancer spreading to bones in females, it is breast. How these bony metastases can look like? Herein, if you carefully take a look, can you see these shadows, these hypodense shadows? These are the metastases in the vertebra. Another picture, beta. If you just take a look at this particular image, now herein you are seeing some hypodense. Transrectal ultrasound guided prostatic biopsy. And we can come to know that yes, this would be an adenocarcinoma. We can do a pathological grading for prostate cancer, and pathological grading for prostate cancer is called as Gleason's grading. This was the question on 4th of June 2022. What is the grading for prostate cancer? Gleason's grading. In breast cancer, we do a Bloom-Richardson grading. Bloom-Richardson grading. Once on biopsy, we come to know that yes, the cancer is confirmed. Then we do staging, MRI. Usually in prostate, we are doing a multi-parametric MRI. Even multi-parametric MRI guided prostatic biopsies are done. So investigation of choice is biopsy, staging, MRI, distant metastasis, PET scan. What is the name of the isotope used in PET scan? 18-fluorodeoxyglucose. Tumor marker for prostate cancer, serum PSA. PSA is prostate specific antigen. In benign prostatic hyperplasia, PSA is actually a prostate specific antigen which is specific for the prostate. It is secreted only by the prostatic epithelium. It is a serine protease. It causes liquefaction of semen, and it can rise in all pathologies of prostate, whether it's BPH or cancer or anything. Usually the values of PSA are between 0 to 4 nanogram per ml, but if the values start increasing and suppose the values increases beyond 10, then it is suspicious of prostate cancer. And if the values are found to be more than 20, 35 nanogram per ml, then it indicates advanced prostatic cancer. What should be the treatment for prostate cancer? Herein, if suppose the cancer is confined within the prostate, then we do a radical prostatectomy, or we can destroy this prostate by external beam radiotherapy. But if the cancer has gone beyond the prostate, then doing a radical prostatectomy is not going to cure the patient. I repeat beta. First, now I repeat in Hindi. अगर प्रोस्टेट का कैंसर प्रोस्टेट के अंदर ही है तो हम प्रोस्टेट को निकाल के कैंसर को क्योर कर सकते हैं, जिसको हम रेडिकल प्रोस्टेटेक्टमी बोलते हैं अगर हम सर्जरी करके निकालते हैं, या हम एक्सटर्नल बीम रेडियोथेरेपी देके इस कैंसर को खत्म कर सकते हैं। लेकिन अगर मान लीजिए ये कैंसर प्रोस्टेट से बाहर चला गया है, इधर उधर चला गया है, तो प्रोस्टेट को निकालने से हम पेशेंट का कैंसर नहीं निकाल पाएंगे। ऐसे केसेस में हमें कुछ और सोचना पड़ता है, हमें हार्मोनल थेरेपी की तरफ जाना पड़ता है, जिसमें हम एंड्रोजन्स को खत्म करने की कोशिश करते हैं। I repeat this in English. If the prostate cancer is confined within the prostate, then this patient can be treated by simply removing the prostate, that is radical prostatectomy or destruction of prostate by external beam radiotherapy. But if the cancer has gone beyond the prostate, then just by doing a radical prostatectomy, you will not be able to remove the complete cancer from the patient. In these cases, there is no point of doing a radical prostatectomy. We give hormonal therapy in these situations. We give androgen ablation in these situations. एंड्रोजन्स को ख़त्म करने की कोशिश करते हैं। एंड्रोजन्स को ख़त्म करने के लिए कुछ दवाइयाँ हो सकती हैं, या एक सर्जरी है जिससे हम टेस्टिस वाला एंड्रोजन का सोर्स ख़त्म कर सकते हैं, जिसमें हम पेशेंट की दोनों टेस्टिस निकाल देते हैं। टू डिस्ट्रॉय और टू ablate the androgen sources, there are various medicines. However, there is one surgery where we can remove at least the testicular source of androgens, that is bilateral orchidectomy. Obviously, by doing a bilateral orchidectomy, we are just removing the testicular source. We are not removing the other sources. So medical castration or medical destruction of androgens would be a better option if the cancer has gone beyond the prostate. Now, another catch here. When we are treating a patient where the cancer is confined within the prostate, we discussed that we can do a radical prostatectomy or external beam radiotherapy. Now, the catch here is, because this cancer occurs in elderly males, suppose an elderly male of 82 years of age comes to you with prostate cancer, and the cancer is confined within the prostate. Should we do a radical prostatectomy or not? Ideally, the guideline says no, you should not. And the simple reason is prostate cancer is a very slow growing cancer. It might take years for the cancer to grow. Maybe the patient will not have any symptoms for 5 years, 6 years, 8 years. Why you want to do a radical prostatectomy and give complications to this patient? The patient is having a good quality of life at 82 years of age. He does not know anything about this cancer. So why you just want to do a radical prostatectomy and give complications of that surgery so that his quality of life deteriorates even at 82 years or 83 years of age? So the guideline says that if the life expectancy is less than 10 years and the cancer prostate is confined within the prostate, just follow up this patient. Do a active surveillance in this patient. If you find that cancer is growing rapidly, then yes, you can go ahead with the treatment. Otherwise, no treatment is needed if the life expectancy is less than 10 years or maybe the age of the patient is more than 70 years, right? So, depending on if the prostate cancer is confined within the prostate, now if the life expectancy is more than 10 years or age of the patient is less than 70 years, then we do a radical prostatectomy. We can also give external beam radiotherapy. However, another story here. If the prostate cancer is confined within the prostate, life expectancy less than 10 years or age more than 70 years, then we just do active surveillance. We just do active surveillance. We keep following up the patient. To do a radical prostatectomy, nowadays we are using robotic surgery. These are the robotic surgery instruments, what you are seeing here. This is the robotic computer console. These are the instruments which are going to go inside the patient. If we take a look at one of the images, how the robotic surgery is being done. This is the robotic operation theater. In this, here is the patient. These are the robotic instruments. Here is the anesthetist. He is the assistant. He is not the surgeon. The surgeon is sitting here in the computer console. And what he's trying to do is, looking at the computer screen, he's trying to move the buttons on the computer. And these buttons are actually connected with pulleys to the robotic instruments. So his hand movement is actually moving the robotic instrument inside. So this is a computer guided surgery. Since it is a computer guided surgery, the surgical precision will be better. This is how the robotic instruments are working inside. That is why robotic surgery is becoming in fashion nowadays, because you can do it through a computer, so you can see the things in millimeters. This is a specimen of radical prostatectomy. Right. So this is how radical prostatectomy can be done with the help of a robot. Another thing, beta, when we are giving this external beam radiotherapy, We use iodine for radiotherapy beta. You can just add this. This was a question on 4th of June. We use iodine 125. It is not iodine 131, but it is iodine 125. We can also use palladium 103 for radiotherapy destruction of prostate. So iodine 125 and palladium 103 are used to destroy the prostate by radiotherapy. The second story what we have discussed is advanced prostate cancer, where we are giving hormonal therapy. We destroy the androgens. We can use some medicines or surgery. Obviously, medical destruction would be better as compared to surgical, because surgically we are just removing the testicular source. So for this, we are doing a bilateral. Please be careful, beta. The examiner may ask that bilateral orchidectomy is done in which cancer. This is actually called as bilateral subcapsular orchidectomy. पेशेंट की दोनों टेस्टिस निकाली जा रही हैं. टेस्टिस में कैंसर नहीं है. Bilateral orchidectomy is being done not for testicular cancer, but for prostate cancer for androgen ablation. So be careful. Regarding medical castration, beta, we can use various medicines like LH-RH agonist can be used. This has also been asked in the exams, like goserelin, buserelin can be used. Goserelin, buserelin. This is a pharmacology question. Which medicine has been used in the treatment hormonal therapy for prostate cancer? Goserelin. We can use androgen receptor blocker. Like enzalutamide. We can use LH-RH antagonist also. Like Degarelix. We can use testosterone production blocker. Testosterone production blocker. Like abiraterone. Abiraterone. Now, the experience says, beta, that this page number 205, this is a favorite page for your examiners, especially in the recent last 3 to 4 exams. So please pay attention to this page. The concept should be absolutely clear in your minds. What is done for the treatment of prostate cancer? We know that it is a part of the aging process. If suppose the cancer is confined within the prostate, cancer gone beyond the prostate. Within the prostate, we have got two options. Either we remove this prostate or destroy the prostate, or just do active surveillance. Cancer gone beyond the prostate, we cannot cure. We just give hormonal ablation, androgen ablation. Cancer within the prostate, if life expectancy is more than 10 years or age of the patient less than 70 years, then we can do a radical prostatectomy, a robotic radical prostatectomy, or we can destroy the prostate by external beam radiotherapy using iodine 125 or palladium seeds can be used, which can be put as brachytherapy in the prostate cancer. However, if the life expectancy is less than 10 years, age of the patient more than 70 years, then we should not do these advanced surgical procedures because they would be associated with their complications. And if the patient is not going to live for 10 years, the cancer itself may take years to grow. Cancer is confined within the prostate right now. Maybe 5 years, 8 years, 10 years, the cancer will grow. So don't do a radical prostatectomy now. Don't destroy the prostate now. Let the patient lead a good quality of life. Do a active surveillance in these patients. Keep a close watch. Keep a follow-up in these patients. Keep calling these patients after every 6 months. However, when the cancer has gone beyond the prostate, then androgen ablation, usually by medicines, various medicines, LHRH agonist, goserelin, buserelin, androgen receptor blocker, enzalutamide, LHRH antagonist, degarelix, testosterone production blocker, abiraterone. These can be used. Surgically, we can just destroy both the testes, remove both the testes. That will reduce the testicular source of androgens. But since medicines are going to take care of all the sources of androgens, so medical castration is better than surgical castration. Not to re-emphasize, beta, that bilateral orchidectomy is done in prostate cancer, not in testicular cancer. Usually testicular cancer is on one side, so we'll be doing a unilateral orchidectomy in testicular cancer. If there is a testicular cancer on both the sides, then definitely we'll be doing a bilateral orchidectomy, right? Chale beta. Another cancer here is penile cancer. Now, most commonly, penis is something which is outside. Herein you can very well see that how these penile cancers can grow. Something like this. There is a fungating lesion seen over the glans penis. This is a squamous cell carcinoma. Most common site is the glans, or you can say the prepuce. We know that the brown color, what we are seeing, these are the corpora cavernosas. The pink is the corpora spongiosa. Majority of penile cancers, they occur in the glans or this prepuce area. Risk factors for penile cancers, जो लोग नहाते धोते नहीं हैं, poor hygiene, human papilloma virus, smoking, long-standing genital warts, which are usually associated with human papilloma virus infection, penile intraepithelial neoplasias, like precancerous conditions or pre-malignant conditions, you can say. On the glans, there is erythroplasia of Currat. On the shaft, there is Bowen's disease. How these patients present to us? Most commonly, there is a ulceroproliferative growth, which is foul-smelling growth on the penis. Now, herein I would like to tell you another important thing. When you'll be working in the hospitals, then if you find a cancer which is exposed to outside, cancer is not only having the cancer cells, but also blood vessels. So there is huge amount of blood in the cancers. And blood is a very good culture media for the growth of microorganisms. If the cancer is on the exposed areas of the body, there is an open invitation for the bacterial party, and majority of these cancers have got that bacterial party inside, which creates a foul smell. And you won't believe that it is so foul smelling that nobody wants to go close to these patients. Even the patient does not want to go close to himself or herself. Many a times, when you will be working in the government hospitals February 23 onwards, suppose there is a queue of 200 patients outside your OPD, and if one penile cancer patient comes, it is so foul smelling that within 5 minutes, 199 people are gone. Only one penile cancer patient is standing in front of your OPD. It's so foul smelling. Any cancer which is exposed outside is usually invaded by bacteria, and there is a foul smelling discharge or maybe foul smelling growth. Obviously, because of bacterial infection, there will be chances of involvement of the inguinal lymph nodes, and not only bacterial infection, but even the cancer cells can go into the inguinal lymph nodes. So the patient can present with enlarged inguinal lymph nodes, 50% of the times these lymph nodes enlarge because of infection, and 50% of the times they enlarge because of tumor. Another thing, beta, sometimes what happens, these lymph nodes become so large when the cancer cells in the lymph nodes are causing swelling of the lymph nodes. These lymph nodes can become so large that they can even erode the major vessels in this area. You know, here would be the external iliac vessel and here would be the femoral vessel. So sometimes these enlarged inguinal lymph nodes causes erosion of the iliac or the femoral vessel, which leads to torrential bleeding, severe bleeding, and the patient, penile cancer patient, dies because of torrential hemorrhage, profuse bleeding due to erosion of the femoral or iliac vessel by the enlarged inguinal lymph nodes. Death in penile cancer patient, this is due to erosion, or you write it as torrential hemorrhage. Torrential hemorrhage means severe bleeding. Torrential hemorrhage due to erosion of femoral or iliac vessels by enlarged inguinal lymph nodes. Now just imagine a penile cancer patient standing in front of you in your OPD in February 23. You are able to see that foul smelling growth on the penis. How will you proceed? You can take a direct biopsy and you can make the diagnosis. So investigation of choice would be a direct biopsy. Any cancer which is exposed outside, whether it is an oral cancer, anal canal cancer, penile cancer, skin cancer, you can take a direct biopsy and that will reveal that it is a squamous cell carcinoma. For staging purpose, you know, we are doing MRI, and for distant metastasis, we are doing a PET scan. Which isotope we are using? 18-fluorodeoxyglucose. Now the best treatment for penile cancer is again surgery, and the margin of resection which we have to take around the tumor is 2 centimeter. Nowadays even 1 centimeter is becoming acceptable. However, the standard guidelines are 2 centimeters. Very simple to understand, beta. Two situations in front of you. If suppose there is a cancer which is situated in the distal part of the penis, which is majority of the case, maybe on the glans or the prepuce, you will take a 2 centimeter margin and you will chop the penis here. This is a partial penectomy. But if the cancer is coming more towards the proximal part, and now if you take a 2 centimeter margin, then if you try to chop the penis at this level, look at the screen, beta. If there was a cancer here and you take a 2 centimeter margin and you want to chop the penis here, what you will be left with is only this area. That means you will be left with only this part. This is the corpora cavernosa and here would be the corpora spongiosa. Only this part. If the length of this part is less than 2 centimeter, it will not be of any use. He will not be even able to pass urine with a less than 2 centimeter penile stump. So, इस पे एहसान करके कोई फायदा नहीं है. There is no point in leaving the small penile stump. It is better to chop the entire penis. Do a total penectomy. Right? Moral of the story, beta. For the treatment of penile cancer, we have got two options. Either we can do a partial penectomy or a total penectomy. The decision to do a partial versus total depends on if you are able to leave 2 or more than 2 centimeters of penile stump, then do a partial. If you cannot leave 2 or more than 2 centimeters of penile stump, then better to do a total penectomy. Now, if you look at the images, This is what is a partial penectomy, and this here is a total penectomy. When you have removed the entire penis, then you refashion the urethra in the perineum as a perineal urethrostomy. Also, what should be done for the lymph nodes here? Because penile cancer patient would be presenting with enlarged lymph nodes. This is actually the erosion. This is a dead person image here. But if suppose there are enlarged lymph nodes, then first we give 3 weeks antibiotics. If the lymph nodes does not resolve, then we believe they are because of tumor, and then we have to remove those lymph nodes. So in the treatment of penile cancer, we can do a partial penectomy or we can do a total penectomy. If preserved penile stump is 2 or more than 2 centimeter, then we are going with partial penectomy. For lymph nodes, we give antibiotics for 3 weeks. If the lymph nodes do not regress, that means they are enlarged not because of infection, but they are enlarged because of the tumor. So we just go ahead with the removal of those lymph nodes. And the last thing in urology cancer is the testicular tumors. This is the most common cancer in a young male. Most common it is seminoma. However, these are actually germ cell tumors. अगर testis ovary की बात करते हैं बेटा, testicular tumors, ovarian tumors, they are having the germ cell. So germ cell tumors would be there. Testicular germ cell tumors can be either seminomatous or non-seminomatous. Majority are seminomatous. Non-seminomatous can be of different types like embryonal, yolk sac and teratomas. The reason for testicular malignancy, most common cause is undescended testis. Undescended testis. And we can very well understand beta that if there is a solid tumor growing inside the testis, this will create heaviness in the scrotum. This will cause enlargement of the scrotum. So majority of testicular cancer patients will come to you with scrotal enlargement. When you examine these patients in the OPD, you know the commonest cause of scrotal enlargement is hydrocele, and hydrocele is having clear fluid inside. So you switch off the lights in the OPD and do a transillumination test. If it is hydrocele, then transillumination will be positive. But if it is a tumor, then the light will not transmit through a solid tumor. So transillumination will be negative. You might be tempted in these situations to put a needle, but never put a needle, because if it is a tumor, when you are bringing the needle back, you will spill the cancer cells in the scrotum. Right. Now, apart from this, to understand about these testicular tumors, we know that testicular artery is a direct branch of abdominal aorta. So the lymph nodes draining the testis would be situated on the aorta. Pre-aortic and para-aortic lymph nodes can enlarge, and patient can present with epigastric lump because pre-para-aortic lymph nodes are situated over the abdominal aorta in the epigastric region. You also know beta that the testicular vein, right testicular vein drains into the inferior vena cava, left testicular vein drains into the left renal vein drains into the inferior vena cava. So whether it is a right-sided testicular cancer or a left-sided testicular cancer, ultimately the cancer cells will be going in the inferior vena cava. Inferior vena cava opens in the right atrium, right ventricle, pulmonary artery, lungs. So the commonest site of metastasis in testicular cancer would be lungs. And just imagine a patient presenting with scrotal enlargement along with blood in sputum. अगर खांसी में, बलगम में blood आ रहा है, and there is scrotal enlargement, hemoptysis with scrotal enlargement suggests pulmonary metastasis in testicular cancer. When we take the X-ray, we see nice cannonball deposits in the lung. This is how the cannonball deposits can be seen in the lungs. Can you appreciate these rounded shadows? These are cannonball deposits seen in pulmonary metastasis, and beta conceptually I am pretty sure that all of you would have in your brains that whenever we talk about distant metastasis for any cancer, we have to just hold on to the draining vein of that particular organ. Because cancer in any organ of the body, if it has to go through blood, it will be going into the draining vein. And just look at the anatomy where that vein is actually going, whether this vein is going into the liver or this vein is going into the lungs. That is how you will decide whether the patient will have liver metastasis commonly or lung metastasis commonly. Breast and prostate, bony metastasis, lumbar vertebra. Right? So I hope you have this concept nicely inside. Transillumination in testicular cancer would be negative. We nicely know this, that transscrotal FNAC or biopsy is contraindicated. Never do this, howsoever tempting it may be. It is better to get the ultrasound of the scrotum done to see whether there is fluid or solid tumor. We can take the help of various markers in testicular malignancies like alpha-fetoprotein, HCG, LDH, and placental alkaline phosphatase. This is alpha-fetoprotein. This is human chorionic gonadotrophin. This is lactate dehydrogenase. The testicular tumor produce these substances, so the levels of these markers may be increased in blood. However, since we cannot take a biopsy and we want to also look at the lymph nodes in the abdomen, so for abdomen we prefer doing a CECT. This is the investigation of choice for testicular cancers. Now, whether it is a seminoma or teratoma, seminomatous, non-seminomatous, that can be proved only by histological appearances, which can be done only when you are taking a biopsy. Open biopsies cannot be done, so we prefer doing a high inguinal orchidectomy. We actually remove this testis along with the spermatic cord, and then the pathologist tells us whether it's a seminoma or non-seminoma. Once this diagnosis is made, then seminomas are radiosensitive, so we can give radiotherapy in seminomas. Herein, the treatment of choice for testicular tumors is chemotherapy. Chemotherapy, wherein we use a combination of BEP, that is bleomycin, etoposide, and cisplatin. This is what we are using in the management of testicular cancers. If you remember the cricketer Yuvraj Singh, he suffered from seminoma in the lungs. Seminomas are radiosensitive. Prognosis of seminoma is better than teratoma, and seminomas spread commonly by lymphatics, while teratomas commonly spread by blood. Any malignancy which is spreading by lymphatics will have a better prognosis as compared to a malignancy spreading through blood. So beta, this is all about the story of urology cancers, and now we are left with thyroid cancer and breast cancer, right? So what we are going to do is, we are left actually with 2.5 hours of class now in surgery. So tomorrow we will be keeping the class from 10 a.m. to 12:30 p.m. 10 a.m. to 12:30 p.m. tomorrow, and there we'll be discussing about the thyroid and breast cancer, and also we'll be revising the entire oncosurgery. Just last one message, that please do watch the video of that 1 hour again and again as much as possible, because that is having all the concepts of oncosurgery. Thank you very much for your patience. May God bless you all. May you all stay focused and pumped up. And may all of you come out with flying colors. Herein, I would like to answer your queries also at this point of time. So those who wish to have the queries, please do write to me on WhatsApp. I am my WhatsApp number is 9999683985. Please do ask your queries on WhatsApp at this number. Just give me a break of 5 minutes, maybe even less than 5 minutes. I'll have to find out where my phone is. So let me just bring my phone and then I'll be responding to your queries right here. Right, beta? So let me just have a look at your queries. Right. And if time permits tomorrow, then probably I might be recording the adult surgical problems revision also, as per the request which I have received from some of you. Janvi from University of Northern Philippines, can you please take the screenshots of the individual questions and please send me which questions you want to discuss. Ruturaj from Karazina, you have sent me some question. Let me read this. Okay, so the question is, what is the commonest cause of hypergastrinemia? So beta, it is atrophic gastritis, which is autoimmune gastritis, or type A gastritis. That is there in your notes also, beta. The commonest cause of hypergastrinemia, it is atrophic gastritis. Chinmay, you are confused about the prostate cancer. Why would the cancer spread to seminal vesicle if it does laterally external side? Isn't the seminal vesicles in verumontanum, which is the very center? No, beta. Seminal vesicles are situated on the posterior surface of bladder. There is a duct coming from the seminal vesicle, which is the ejaculatory duct, which opens in the prostatic urethra, not the seminal vesicles, beta. Seminal vesicles are behind the urinary bladder. Okay, please mention your university, Chinmay. Parth from Odessa, beta, paraneoplastic syndrome. The tumor produces certain substances which can be associated with raised calcium levels like hypercalcemia, maybe raised ESR, leukocytosis, and so on. Why there is positive urine cytological evaluation for bladder and not for kidney? It is positive for both, beta. Parth, kidney and bladder cancers both. Urine cytology will be positive for cancer. Picture from Our Lady of Fatima, beta, how the patient will urinate after total penectomy. Beta, as you saw that we are doing a perineal urethrostomy. That means we are refashioning the urethra in the perineum. Now this male after total penectomy will pass urine just like a female. Ahmed from Orenburg, Goodsall's rule in Hindi. Goodsall's rule बेटा जो फिस्टुला इन एनो के लिए हम करते हैं उसमें अगर मान लो हम पेशेंट को लिथोटमी पोजीशन में ले लें जिसमें प्यूबिक सिम्फाइसिस अपना ऊपर की तरफ है और सैक्रम पीछे की तरफ है जो नॉर्मली होता है, अगर हम एनल ओपनिंग को ठीक दो भागों में हॉरिजॉन्टल लाइन से बांट दें तो यानी कि जो हिस्सा एनल ओपनिंग के आजू बाजू वाला है वो प्यूबिक सिम्फाइसिस की तरफ वाला जो हिस्सा है उसको अपन एंटीरियर बोलेंगे और जो सैक्रम की साइड वाला हिस्सा है उसको पोस्टीरियर बोलेंगे। अगर मान लो फिस्टुला की ओपनिंग हमें एंटीरियर एरिया में दिखाई देती है तो ये फिस्टुला जो होते हैं इनका जो अंदर एनल कैनाल तक रास्ता जा रहा है वो सीधा सीधा जाता है, यानी सर्जन को आसानी रहेगी इन रास्तों को निकालने में। लेकिन अगर एक्सटर्नल ओपनिंग फिस्टुला की पीछे की तरफ है तो ये जो पोस्टीरियर फिस्टुला होते हैं इनका जो रास्ता एनल कैनाल की तरफ जा रहा होता है वो टेढ़ा मेढ़ा होता है लेकिन हमेशा ही मिडलाइन में खुलता है पीछे की तरफ। Another query about the anastomosis after total esophageectomy. We are doing anastomosis of stomach, so there will be no problem with the pancreas and duodenum relation during this. Definitely, beta, there will be problem. We are just trying to mobilize the stomach. We are not trying to mobilize the duodenum in these cases. We make a tube of the stomach. So duodenum pancreas will not be facing any issues as such. I hope the last 5 digits 83030 beta. Please do mention your name and university. Thank you beta. Your doubt is cleared. God bless. Murari from Volgograd beta. Very good evening to you. When we are doing urinary diversion after radical cystectomy, is there a chance of continuous dribbling of urine? What we do beta, we are not directly putting the ureter in the ileum and colon as such. We actually create an isolated loop, and that is just imagine a 15-20 centimeters loop of ileum which is isolated from the GI tract, and now we are putting the ureters there and the outer end of that isolated loop is taken out of the abdominal wall and we just put a bag on that ileal loop. So urine keeps on coming in that bag. We just keep on emptying the bag whenever the bag fills up. Yatra from Penza beta, difference between polyp and juvenile polyp. Beta, there are n number of polyps what we come across. Juvenile means innocent. Usually these juvenile polyps are seen in small babies in the rectum. They are called as cherry tumors. They usually do not cause any malignancy. But if there are adenomatous type of polyps, then there are more chances of malignancy. Isha from Ama beta. In nephroblastoma there is abdominal mass, then why are not using the USG is the first investigation, Isha. We know from the WOW, can we do HIDA scan in carcinoma gallbladder? We can do HIDA scan, but what is the use of doing a HIDA?
That will just to show that the tumor inside the gallbladder is not getting filled up with the isotope. So we'll not get the desired information. We'll not be able to see the mass. Abhiti from Davao, blessed to hear such nice words of appreciation, beta. We are very thankful for your endless work for us. Thank you, beta. God bless you always. Secondary lymphedema is due to removal of lymph nodes during mastectomy. There won't be any problem in removing inguinal lymph nodes in penile cancer. Yes, beta, there will be a problem. If we are removing the inguinal lymph nodes, the patient will have the chances of lymphedema of the lower limb. Definitely, it will be there. Ajay, very good evening to you, beta. If we are performing a total, then how would be the patient pass urine? Beta, if you are doing a total penectomy, then you are refashioning the urethra and the perineum. So now this male, after total penectomy, will pass urine just like a female. Aman, beta, please do mention your university. You have a doubt about an adult kidney cancer. What is the chance of increasing the risk of spreading cancer from affected kidney to normal kidney? Very rare. Is it necessary to know extra about Bowen's disease or only names? Names are more than sufficient, beta. However, this Bowen's disease, erythroplasias, they will be discussed in dermatology classes as well. Anindita from Kiev, beta. Can't we do MRI in testicular cancer? Uh, if we just want to know about the scrotal area, we can. But in testicular cancer, we also want to know about the abdominal area for the prepariotic lymph nodes. What is the reason of calcium deposition in porcine gallbladder? Maybe defective calcium metabolism. In which cancers we can't do PET scan? Generally in urinary cancers, kidney and bladder cancers, because the 18-fluorodeoxyglucose is excreted through the urinary tract. So many times we are not able to find the cancerous tissues in the kidney and bladder region. Oh, we forgot to write about the spread of prostate cancer. Just a moment, beta. Just a moment. I think we have written here the prostate cancer locally spread upwards and laterally to seminal vesicles. Urethral involvement is late. Through lymphatics, the prostate cancer is spreading to obturator lymph nodes, then to internal iliac lymph nodes. Through blood, the prostate cancer is spreading to lumbar vertebra, that is to bones, and through the vertebral beds and plexus of veins. Usually, these bony metastases in prostate cancer are osteoblastic. In other cancers, they are osteoclastic. Thank you. Thank you so very much, beta. I think I have not saved your name and university. Please do mention your name and university, beta. I might have missed out. Vikram from VNMU. Now this is Vinnytsia National Medical University, I guess. You said radiotherapy is contraindicated in squamous cell while varicose vein complication. It is not contraindicated in squamous cell carcinoma and Marjolin's ulcer, but it is not the treatment of choice. It is not very effective. In anal cancer, we are doing radiotherapy and chemotherapy. Yes, earlier, just because of this reason, we were not using radiation, but now we have seen that radiotherapy alone is not going to be effective. But if we combine it with chemotherapy, then yes, it is effective for anal cancer.
Deepak from Kathmandu. What do we do inferior testicular vein joining to the left renal vein when the left kidney is transferred for transplant? Beta, the left testicular vein is actually connected to the left renal, to the inferior vena cava. The last 5 digits 48927. Hello sir, good evening बेटा. आपकी वजह से अभी सर्जरी बहुत easy लगने लगी है. The way you revise, thank you so much for giving us knowledge. Thank you for keeping us motivated all the time. Thank you beta. Thank you for so nice words of appreciation. May God bless you beta. Please do mention your name and university so that I can save you in my contacts. Varsha from UV Glass, very good evening to you, beta. Not sure if I can ask this, but what is usually done in active surveillance, close monitoring for someone with prostate cancer? Beta, we keep following those patients with multi-parametric MRIs on a 6-monthly basis. Firdosh from Uzgrowth, beta, if we do total penectomy, how urine comes out after total penectomy, beta? The urethra is refashioned in the perineum, and now this patient will pass urine just like a female. Also in proximal gastric cancer, total gastrectomy, why we are doing splenectomy? That is because in proximal gastric cancer, the lymph nodes situated on the short gastric vessels, they would be involved in cancer. And if we trace those lymph nodes situated on the short gastric vessels, the lymph nodes are actually going deep into the hilum of the spleen. So it is very difficult to remove just the lymph nodes if the lymph nodes are embedded almost inside the spleen. That is why we are doing a splenectomy, to remove the lymph nodes for adequate lymphatic clearance. Shlok from Janil Tabita, thank you for today's onco session, sir. I always suffer with this topic. It cleared quite a lot of concepts. Definitely difficult. We'll need to invest some time to understand it more clearly. Thank you, beta. Thank you so very much. Shlok, I would just like to say the same thing again and again, that first 1 hour or 1.5 hours of onco surgery, if you just listen to that again and again at a fast speed if possible, which is not possible in iOS devices, but if you can do that, that is really going to help you. And tomorrow again we'll be doing that revision. Ashutosh from Northern State, beta, very good evening to you. My doubt is that if we have done total penectomy, what will the management done for the urination? See, so many of you have asked this question. That means it is my fault, my mistake, that I should have mentioned this, that if we are doing a total penectomy, then the urethra is refashioned in the perineum, and now this male will pass urine like a female. And why is scrotum being kept and not been removed as shown in the picture of the workbook? Why? There is no need to remove the scrotum. The cancer is in the penis and not in the scrotum. Ankush, please do mention your university, beta. I think in prostate cancer, I've mentioned the spread. Locally, the cancer spread upwards and laterally, involving the seminal vesicles. Urethra involvement is late. Through lymphatics, it spread to obturator lymph nodes and then to internal ileate lymph nodes. And through blood, it most commonly goes to bones. Through the Betson's lumbar vertebral plexus of veins, it goes to the lumbar vertebra. Bony metastasis in prostate cancer are osteoblastic. Bony metastasis in other cancers are osteoclastic. Sheikh from Kiev, beta, very good evening. Veins are one of the ways of cancer spread. All veins are draining to the heart. Then why cancer in the heart is rare? Wow. Because the heart is continuously pumping, beta. The cancer cells do not get time to stay in the heart. They continuously keep on moving out from the heart. Salim from Northern State Medical University. This is, sir, this is the bestest experience of my life to be taught by you. आप बेस्ट हैं. कभी इतना मज़ा नहीं आया मेरे को पढ़ने में अपनी लाइफ में. लॉट्स ऑफ लव एंड रिस्पेक्ट. लॉट्स ऑफ. आई विश आई विल नॉट लेट योर हार्ड वर्क इन वेन. Thank you so very much, Pita. It is really a pleasure to read such lines. One question, you taught a lot in yesterday's class. You taught a lot in today's class. This is our first attempt. Many students here are repeaters and they know the concept. They have to just revise, but for us, we have to learn everything. Last day, I still have 2 pages to learn, and now today is a lot of things to learn, and still I have to revise all adult surgery. If I didn't get time, how will I revise? I hope, Salim, that you are getting plenty of time tomorrow, and then there would be a Tuesday also coming up, Pita. Please try to complete the lessons on a daily basis. For this, I would like to tell you, Pita, to everyone, that it is not the duration of study which is going to matter, but it is the intensity of study which is going to matter. It is not that if somebody is sleeping at 4 o'clock in the night and waking up at 7 o'clock in the morning that he is reading a lot. Even if somebody is studying up to 1 o'clock in the night and waking up at 7:30 in the morning, still, if the intensity of study during the study hours, if he keeps himself pumped up, then definitely this is going to give you better results. Just imagine that every day is a test day, because on Tuesdays, the intensity of your study is really high. So you are pumped up. You tend to retain that more on Tuesdays, whatever you are reading. So try to just imagine that every day is a Tuesday and go ahead with the same pace. Thank you very much. Varna from Davao, beta. Page number 205 is investigation of choice is transrectal ultrasound guided prostatic biopsy. We don't do a transurethral ultrasound guided prostatic biopsy, beta, because urethral diameter is very small. We cannot pass the ultrasound probe through the urethra. LHRH agonist and antagonist help in medical castration, beta. This luteinizing hormone releasing hormone, when we'll be reading these hormones in other subjects, we'll come to know that it is the pulsatile nature. It is not that we are giving them continuously, but we give them as a pulse. So they inhibit the axis which is controlling the release of these hormones.
Guru, Semi State Medical University, Kazakhstan.
Just a moment. Sunisha from Hebei, beta. The LHRH agonist antagonist, basically it is the pulsatile nature of these releasing hormones which blocks the axis which is releasing the testosterones. So we can use the agonist as well as the antagonist, that doesn't matter, but it is the pulsatility, that is, instead of giving a continuous injection, if we give them in pulses, that will inhibit the axis which is responsible for releasing the hormones like testosterone. So we just want to ablate the testosterone, beta. We don't know what is the exact cause of prostate cancer, but it is thought to be related to androgens. So we are trying to ablate the androgens, and this has really given us effective results. Just a moment. Muhuzina from Wuhan, how to differentiate between infantile and congenital hydrocele. Basically, if there is a swelling which is confined within the scrotum and the inguinal canal only, then it is a infantile hydrocele. But if it is connecting with the peritoneal cavity, then it is a congenital hydrocele. To differentiate them, beta, when the baby presents to you, when the patient presents to you, if you are able to see the swelling in the inguinoscrotal region which does not reduce, that may be infantile hydrocele. But if on lying down the fluid goes back into the peritoneal cavity and the swelling reduces, that would be a congenital hydrocele. Krishna from the wow, beta, after total esophagectomy, the sphincters are not. So, what are the complications without sphincters? Definitely, beta, there would be refluxes, but whenever we are doing such major surgeries, we have to weigh the pros and cons. If we feel that patient will get advantage, if we remove the cancer, then we take the risk of those complications. Ashika from Volgograd, beta, I have doubts, so tomorrow we'll be done with oncosurgery and join the online from 1st August. Will the rest of the be also taught in live? Beta, I would strongly recommend, Ashika, that if you are able to complete those videos, that would be really helpful for you, because that will really save your time in the end. So if you are able to do that, go ahead. Otherwise, it will be done again later on, but that will be really late. D. Silva from Stavropol, beta, from your doubt, you said BEP. Cisplatin starts with C. Yes, beta. P stands for platinum, right? So P is for platinum. Cisplatin is a platinum-based medicine. So that is why we are writing BEP. Sumit from Orenburg, thank you, beta. Your query was how will the patient pass urine after penectomy? Thank you. Riddha from Bogomolets, beta. In case of total any reconstruction for micturition, we just refashion the urethra and the perineum, beta. Gleason's and Richardson grading, beta, these are pathological grading, which are actually based on the mitotic activity, the pleomorphism, and the tubule formation, what we see. Based on that, we can grade, like Gleason score ranges from 0 to 10. If the Gleason score is between 0 to 6, then there is no need for any active intervention, because that is a slow growing story. But if the score is above 6, that means 7 to 10 Gleasons in a prostate cancer, then it is an aggressive type of cancer, and it is better if we do some surgical intervention early and remove the prostate. Bloom-Richardson grading is used in breast cancer, where we can differentiate the breast cancer into well-differentiated, moderately differentiated, and poorly differentiated cancers. That will decide the aggressive nature of those cancers, depending on the mitotic activity taking place inside the cancer. मैथिली फ्रॉम तक्षशिला अमेरिकन यूनिवर्सिटी, ए कैलकुलस कोलिसिस्टोपैथी इन हिंदी। बेटा, जब गॉल ब्लैडर में कोई पत्थर नहीं है और गॉल ब्लैडर की जो दीवार है उसमें जो मसल्स हैं, जब वो मसल्स की शक्ति कमज़ोर हो गई है, तो यानी कि जो गॉल ब्लैडर के कॉन्ट्रैक्शंस हैं जिससे वो बाइल को पंप करता है, वो कॉन्ट्रैक्शंस कमज़ोर पड़ गए हैं, तो बाइल जो है गॉल ब्लैडर से निकल नहीं पा रहा सीबीडी में आराम से। तो उससे क्या होगा बेटा, बाइल जो है गॉल ब्लैडर में रुका रहेगा, और रुका रहेगा तो पार्टी हो जाएगी, पार्टी हो जाएगी तो फिर वो गॉल ब्लैडर में एक्यूट इन्फ्लेमेशन हो जाएगा और गॉल ब्लैडर गुस्से से लाल सूज जाएगा, और पेशेंट बिल्कुल वैसे ही प्रेजेंट करेगा जैसे हमने एक्यूट कोलिसिस्टाइटिस का प्रेजेंटेशन देखा है। Ashok from Far Eastern Federal University, please explain about transhiatal esophagectomy in esophageal cancer. Transhiatal is something beta which we are doing through the abdominal route, especially when the cancers are situated in the lower esophagus. What we can do is we can make an incision in the abdomen and another incision in the neck. So we try to mobilize the esophagus from the abdomen, hiatus, that means through the opening in the diaphragm. We try to dissect the esophagus from that area into the thorax, and a cervical neck opening, we try to dissect the esophagus from above. So without opening the thorax, sometimes we are able to dissect the entire esophagus. That is what is a transhiatal esophagectomy. Shobika from Far Eastern, yes beta, you will be having all these topics again in future, but it is strongly recommended because we are already starting on 5th of August, so we don't want to lose on time later on. Let us try to save as much time as possible in the revision period. Rishi from Tambov, TNM classification बेटा, T मतलब ट्यूमर, N मतलब लिम्फ नोड, M मतलब मेटास्टेसिस। आप किसी पर्टिकुलर कैंसर का TNM बताना है तो बताओ बेटा, या सारे कैंसर्स का मैं बोल देता हूँ एक बारी। जैसे GIT में हमने लिखी है ये TNM क्लासिफिकेशंस। ईसोफेगस में T1 सबम्यूकोसा, T2 मसल, T3 एडवेंटिशिया, T4 एडजेसेंट ऑर्गन्स, T4A प्लूरा पेरिकार्डियम डायफ्राम, T4B ट्रेकिया बोन एओर्टा, N1 1 to 2, N2 3 to 6, N3 7 or more than 7 lymph nodes, M1 distant metastasis. स्टमक कैंसर में T1 सबम्यूकोसा, T2 मसल, T3 सबसिरोसा, T4A थ्रू द सिरोसा, T4B एडजेसेंट ऑर्गन्स, N1 1 to 2, N2 3 to 6, N3 7 or more than 7 lymph nodes, where N3A 7 to 15, N3B more than 15, M1 distant metastasis. कोलोरेक्टल कैंसर में T1 सबम्यूकोसा, T2 मसल, T3 सिरोसा, T4 एडजेसेंट ऑर्गन्स, N1 1 to 3 lymph nodes, N2 4 or more than 4 lymph nodes, M1 distant metastasis. If a 90-year-old male is on catheter from last 1-2 years, suffered from prostate swelling by nerves, so what would be the diagnosis? Does he have prostate cancer? Need to investigate whether it's a benign prostatic hyperplasia or prostate cancer. Thank you so much, Rishi, for sharing this nice photograph in Tambov, where Prashant sir, me, and all of you are standing behind. Lovely picture. Thank you, beta. You just made my day by reviving the old memories. Thank you. I think this is just before the COVID, 7th of March or 6th of March, I guess, 2020. Yeah. 6th of March 2020, I guess. I really miss Prashant sir a lot. He is a gem of a person and very close to my heart. If possible, please do convey my sincere loved regards to Prashant sir. Hope it's clear, Deepak. Anshula from UNP, beta. Thank you very much for the information. Thank you, beta. Thank you. God bless you, Anshula. Afam from Chencho. Is there any chance to spread cancer cells while doing biopsy, or rather how it is done without spreading? You taught that in direct pricking there are chances to spread. No, beta. If the cancer is exposed outside, then we can directly take a biopsy without any spillage of cancer inside the body. All those areas in the body where endoscope can go, you can take an endoscopy and biopsy without spilling the cancers anywhere inside the body. Pancreatic cancer, yes, distal pancreatic cancer can go to spleen, beta. Priya from Davao, beta. Very good evening. In urinary diversion, we are connecting the ureters in ileal or colon, but there will be increase of infection. Yes. Can you please explain fat embolism, which is common in bone fracture? I think the orthopedic faculty would be the best person to explain fat embolism in detail. Yes, we can do penile reconstructions, but the results are not very good. So there we do penile reconstructions and put penile implants there. Neeti from KNMU, but I think KNMU is Kazakh National Medical University, if I'm not wrong. Very good evening to you. Can you X-ray on page number 204, prostate bony osteoblastic metastasis, which was some glitch in the video? Yes, beta, why not? I'll just do that right away. Please look on the screen. If you can just have a look here. Now, this, what you're seeing is the hypodense shadow here. So this is the site of metastasis. And now I'm just removing this from the speaker mode. I hope you are able to see this beta. I'll zoom it further. Can you see this hypodense shadow here? So that is how the bony metastasis may look like. Another thing here, if you see Normally you don't see these hypodense shadows. Can you see this rounded hypodense shadow? This is how the metastasis looks like. How to differentiate between umbilical and paraumbilical? It is very simple, Niti. If the story is coming out through the umbilicus will move in a forward direction. Umbilicus will come forwards. But if it is a paraumbilical hernia, then umbilicus is not going to come out. But there will be a herniation from around the umbilicus. So there would be a bulge seen from around the umbilicus. Umbilicus would actually be dipping in. So umbilicus would be C-shaped or crescent-shaped in paraumbilical. Okay, Ji. I understand, beta. From Kharkiv, let me just go through the questions. Till which pancreatic cancer stage operation is possible? Till the time the cancer remains confined within the pancreas, not involving into the portal vein completely, not going into the liver. Oh, I'm really sorry, beta. Thank you, beta. Thank you so very much. I do respect. And whenever you don't want your name to be said, please do mention in that same message only so that I don't speak that name out. Otherwise, in auto mode, it will come out. Screening test for detection of cancer before symptoms appear. Like for cervical cancer, we are doing a pap smear. For breast cancer, we are doing screening mammography. For prostate cancer, we can go ahead with DRE and digital rectal examination and prostate specific antigen. Thank you very much, Ashok, for your kind words of appreciation. Permanent treatments for grade 1 hemorrhoids is avoid constipation and get the sclerotherapy done. Preeti beta, please do mention your university. What are the specific tests to differentiate BPH and prostate cancer? That is a multi-parametric MRI. And the best would be the biopsy. Second, in urinary TB, which is the earliest change we can see, ulcer at renal papilla or moth-eaten ulcer at renal papilla beta. Gradually, then the calyces will be eaten up. The moth-eaten is also an early change, but ulcer will appear earlier than moth-eaten appearance. Right, Vida. Thank you very much. Thank you for your patience. May God bless you. Wish you all the very best. May God give you all the strength and courage to keep grinding, keep grinding, keep grinding on a daily basis. Good night. See you tomorrow, 10 o'clock.